Okay, I think John has, it's the last study we looked at. John has the arthroscopic grading system in Campbell's that he's going to read us concerning biceps instability. Go ahead, John.
Okay, direction of instability, anterior, posterior, anteroposterior. Extent of instability, none, subluxation, dislocation, no numbers. Lesion grade, normal 0, minor lesion 1, major lesion 2, rotator cuff tear slash lesion, A intact, B partial thickness, C full thickness. That's it.
Okay, I'm ready. Thank you,
Uh,
John.
it's something that you just described in your report. That's about it.
Okay, thank you. All right, Tayson, what do you think of this case? So again,
All right.
if you remember, the last case we had was of this patient who had uh, a grade 1 lesion, my old grade 1 lesion. What about this patient?
This one looks like the biceps tendon is subluxed into an interstitial tear of the
Okay.
subscap.
So there you're actually seeing
Yeah.
now, we saw a number of cases where the biceps, which we'll see next, was located in the joint space with what looked like an intact overlying subscapularis. And finally, one day we had this case where we actually caught the tendon in the act of cutting through the subscap. I think this typically, once it gets to here, typically cuts its way through pretty rapidly, probably within a few weeks or months. Here you can see that those superficial fibers of the subscap go all the way over and are portion, and here's the transverse ligament here all intact. So you can see how the biceps tendon subluxes into the subscap and then it'll tear its way through the deep fibers, and you're left with still an intact subscap in the process. And then often the deep fibers will heal to the lesser tuberosity, or sometimes they won't, and you'll just be left with kind of a partial tear of the distal subscap, which was thinning there. So this would be my old grade would be a 2. This would be a Habermeyer 3 because we have I tear the superior glenohumeral ligament. Otherwise, the biceps can't dislocate out of the intertuberous groove, and now it's into the subscap. So that makes it a 3. If the supraspinatus is also torn, then it would be a 4. Okay, and then here's one where we can see the lung head. This is an old study. This we can see the lung head. The biceps tendon is now steady again here in the joint space, and the subscap is intact. But then if we look at what we know now, these are the superficial fibers. We can see that they continue over into the transverse ligament, but the deep fibers are really torn here, and you have a very thin distal subscap tendon. So this is what I call the grade 3 with interarticular biceps dislocation. Ready?
Well, John,
Yes.
it would have to tear the fibers all the way to be able to get there.
No. See, John, it initially what it does, the biceps sublux into the substance of the subscapularis. The superficial fibers are still intact here. And then what happens is the pull is this way on the biceps tendon to the anchor that's over here, and it'll tear itself through the deep fibers, but these superficial fibers may still stay intact.
No, I see on that one, the inferior margin of the subscap has a very thin layer left, but the next slide that you have, that one, how did that get there from up there? Did
you
it go over
the superficial
the
fiber.
top of the tendon? No.
Well, so what happens is that the biceps subluxes into the tendon, and then the superficial fibers are intact, like we see here, and then they'll tear
Yeah.
through the deep fibers, but the superficial fibers may or may not stay intact. So most of the time, the superficial fibers stay intact, and we'll see a dislocation of the biceps tendon into the joint space, but the subscapularis tendon has only a deep partial tear. The superficial fibers don't tear.
So it sneaks underneath it.
It
Okay.
sticks underneath just through the deep fibers, right? Yeah, it
Right.
took us
Okay.
about a year to figure that out. Yeah.
Got it.
Okay.
Okay, so here, again, on the axial view on the left, we're seeing medial subluxation of the long into the biceps into the, well, it looks like, yeah, the fibers of the subscap, but there's a pretty significant tear of the subscap with retraction.
Yeah, so what this one is, this one tore itself through the transverse ligament
Mm,
and ended up anterior to the subscap.
yeah, okay.
So this is really an extra articular dislocation of the biceps. This is about 15% of the. Just one second. Hi, Ryan. Okay, I'm in the middle
It
of
just hasn't. Eventually, I would think
call you
it'll
back.
probably come
Thanks.
through.
I'm sorry, John. What was that?
I think eventually it'll probably saw right through it.
Yeah, maybe so. Maybe so. You guys remind me, I've got to make a
It
phone call.
depends on the patient's activity.
Yeah. So this we labeled a grade 4, which is an extra articular dislocation.
All right, so this is a 58-year-old female with pain and limited range of motion. Rule out cuff tear. The biceps again looks like it's anteriorly dislocated and
Yeah,
anterior to the
a lot of
subscap.
tendinopathy in the subscap here. So this must have been an arthrogram injection. So some of this could be due to the injection.
So do you think that transverse ligament is a scar at that point right there?
Here, so
Yeah.
the question is the transverse ligament scarred in here? My guess is it kind of tore through the transverse ligament, and there's probably a little membrane that formed there, but it's probably not a full ligament.
One thing to remember, like we talked about the other day, the transverse ligament is quite long from superior to inferior, and it may be not a complete dislocation distally. It may be more complete as we see here, more proximally.
Okay, thank you. So we already saw this case last time, I think. So let me. Okay. Actually, this is a different case. Sorry. Greg, what do you think of this one?
Oh, I think I did have this case because it was a bifid biceps with the vincula.
Yeah, with the vincula. So this we were looking at the variance of normal. Now we can see that there are these two components, a bifid, congenital bifid biceps, and we know it's congenital because both of these have vinculas associated with them. Okay, and then I think this is the same patient, might be a different patient, but what do you think here?
So here we have an axial view. I see the biceps tendon, but it looks like a portion of the biceps tendon may be medially perched or subluxed.
Yeah, so one of them is subluxed here anteriorly, and the other one is in the proper location.
Well, could it be that the biceps is split?
Yeah, but it's a congenital, John, because if it's a longitudinal tear, then you won't see the vincula on both segments. If it's congenital, then you'll see the vincula on both segments. So both of them had vinculas here, so this was a congenital biceps, pretty rare. And here it just shows the anterior one is subluxed. Okay.
Can you hear that saw next door?
I do not hear a saw, no.
Okay, good.
All right, this looks like a full thickness tear of the subscapularis. Is
Okay.
that ovoid low signal or biceps tendon immediately dislocated?
Okay, so this time we have a complete subscap tear, dislocated biceps. This was number 5 in our criteria, and this turned out to also have a tear of the supraspinatus, so this was a Hagemeyer 4.
Okay. So we have an effusion. I see. Do we have a subscap tear? And again, just is that medial subluxation?
Right. So this is again.
Yeah, again.
5. Again, don't remember
What's the moral of the story?
the moral of the story is that's a lesion you'd prefer not to get.
81-year-olds shouldn't be throwing.
Okay, that's the moral. That's good. That's a good moral. All right.
All right, so we have a 28-year-old male with shoulder pain after a motorcycle accident.
Okay, so what do you see here?
I think I see the biceps, and there's a lot of edema surrounding.
Okay, so there's one cut. Here's the next cut.
Okay.
The next cut.
Oh,
The next cut.
looks like it's laterally subluxed and
Right.
going.
So
Posterior?
Not subluxed. No, the word is dislocated.
Yeah.
yeah, so this is what our criteria would be a type grade 6. This is a posterior dislocation, pretty rare event, and typically it takes a high level of trauma, in this case a motorcycle accident, to do it. Okay.
Well, at least he's alive.
Right.
Okay, so we have looks like 2 axial images, and then is that a coronal or
This is a
sagittal? Sagittal. So on the first, it looks like the subscapularis looks okay. The I don't see the long head biceps tendon in the groove.
Okay.
And then is this more inferior? I guess that's looks like a thickened biceps tendon, and then, yeah, so it's a complete rupture of the biceps tendon with
Yeah.
retraction.
That's a complete rupture, which we listed as our type 7. Yeah. And then here's another low field scanner, again showing absent biceps in the intertuberous groove, a lot of hemorrhage and distal retraction of the biceps tendon. And we can see all the hemorrhage and edema here distally. And that was a type 7 with big hematoma associated with it.
Clinically, they call it incorrectly a Popeye sign.
Right,
It's
exactly. That's right.
Popeye actually had the forearm bulges from eating.
So John's a connoisseur of old comics. Good. Thanks, John.
Eating spinach. That's what you get.
All right, so where I expect the biceps to be, I don't see one. I just see fluid in the sheath.
Okay. So it looks like it's torn,
Yeah.
but if we go approximately, that's the biceps anchor.
Looks like there might be a slap tear there, but the rest of it looks
So this actually was uncommon. Almost always the biceps tears proximally around the anchor. This was one that actually tore in the intertuberous groove. So it was more a distal tear than the normal tears.
Okay, pain and decreased motion. Biceps. It, some irregularity, kind of that rotator interval, maybe that. I mean, is that the, well, what are we pointing to there? Is that the
So
biceps tendon?
this is the biceps, actually. That's the
Okay.
biceps anchor. And what can happen when you have these rare tears that are in the intertuberous groove is that that proximal portion of the biceps can flip around and be a mass effect within the joint and produce intermittent pain and locking. So often these have to be removed, and then you do a more distal biceps tenodesis.
Okay.
If the patient wants
Yeah.
a much faster recovery if you just leave it alone.
Okay.
All right, so we have a 53-year-old female with pain and decreased range of motion. Looks like there's some supraspinatus tendinosis, and then the superior labrum looks like it's increased in signal.
Okay.
And then there's a very thin biceps tendon, so I think it's torn and probably retracted.
Yeah. Okay. So the history was the patient had a biceps strain.
Bicep strain.
Patient's a big weightlifter.
So 54-year-old male with bicep strain. Axial views. I'm not sure if I even see the biceps tendon. Maybe on that view, maybe there's some sort of remnant. So it's torn, and is it into the joint space?
No.
Is that right there? Yeah. That's the biceps tendon retracted down into the joint space.
Yeah. So this was even a bigger loose body. So you can see how if you have this big, this is all the proximal stump of the biceps, and it can produce a major mass effect within the joint space, which can cause a lot of dysfunction, pain. It really acts like a loose body in the joint space, or can. This is pretty rare. I've only seen a few of these. The ones I've seen, I think, are all in the lecture here.
All right, so in the sagittal T2, we see a soft tissue fullness rotator interval region, and I think I see a stub of the biceps tendon. Yeah, there in the groove. So
This is just to remind you that the rotator cuff interval scar, which we'll talk about in a different lecture, is right in this same area and can sometimes obscure the visualization of that long head of the biceps tendon. Okay.
Okay, so there's been some postoperative change in the bicipital groove, maybe a bicipital tenodesis.
Right. So this is the biceps tenodesis. Now, up until recently, most biceps tenodesis were done by many open procedure where you would go in and you would attack the biceps tendon down to the proximal humeral diaphysis externally. Now, since a lot of these patients will get surgery and at arthroscopy, you'll see that there's a lot of disease of the biceps tendon. They develop techniques to be able to do the biceps tenodesis arthroscopically at the time of the surgery, like was done in my shoulder, which you all guys saw. So most of the tenodeses I see these days are intra-articular biceps tenodeses, which are done arthroscopically. This actually is a anterior supraspinatus tendon repair, and this was a biceps tenodesis back over here.
And I don't know if I like a threaded screw going through the biceps that kind of cuts through the biceps and that may subject the patient to tear. There are better techniques than that.
Yeah, I think most
One
people.
of them is a loop technique where they put a loop around the biceps tendon and then suck it into the head, into the um, humerus.
Okay.
All right, so we have a
I
50.
can't explain the loop because it's kind of difficult to do.
Okay.
All right, so we have a 50-year-old with biceps tenodesis with interference screwed 2 weeks ago. Patient fell 3 days ago, and they want to rule out a biceps rupture. I do see that, I guess, anchor in the proximal humerus, and that uh, biceps looks kind of frayed. And
Yeah, it's a little bit frayed into here. So we did an oblique sagittal sequence and through here, getting cross section. This is what it looked like.
uh, yeah, superiorly looks frayed and increased in signal, but looks like it's probably still intact.
So we told, yeah. So we told him it was intact, and the patient.
And this one probably had loops around it. Um, and this one is a suture anchor.
Okay.
So
Okay.
it's a decent tenodesis, but it's outside the joint. So
Right.
I don't know why. Well, apparently the patient wanted. Was that a female?
I don't know.
Not too much muscle. That's not a female. That's a male. I usually guess pretty good, John.
Yeah.
Okay. So 57-year-old male, 6 weeks after injury, evaluate for muscle strain. So we have an axial view. It looks like the biceps tendon is in the groove. The subscapularis. I see the subscapularis tendon. There's another, almost looks like another tendon posterior to that.
This one.
That there.
Yeah, just the two different. It's all the subscap here. So
Is
what's this and what's that?
So it's the biceps tendon is in the groove, but the structure above it is that's not the is it wouldn't be the accessory head, would it?
Yeah, that's probably the accessory. Good. Okay, keep following this. What's happening over here?
So I have wood collection. I'm not sure.
Back again. Okay, so you can see all the biceps over here. So what's going on over here? Notice we've got some fluid here.
Mm-hmm.
It's anterior to the subscap, and so in this area, and then there's all this fluid here. So what is this? What is this structure right here?
The biceps anchor.
Well, this if we had one cut up, it'd be easier because one cut up, you'd be at the coracoid process.
Mm-hmm.
So what attaches to the coracoid process?
The
Notice how regular this is. There's fluid around it.
is it the would be the coracohumeral.
And then here we got this.
Oh, is it the pecmi? No. Oh, sorry.
Yeah, but that's actually a partial tear of the short head, not the biceps,
Oh, okay.
coming over to the coracoid process.
Whoa. Is that a bony fragment in the biceps groove?
Okay. So there's a biceps, and there's a loose body, Here we can see it. So you can also get loose bodies down in there.
Okay, radiographs. Okay, nothing's jumping out, but
Alrighty, let's go to the MR.
right, some irregularity with this muscle and along the distal humerus. Maybe it's probably the biceps. Um, where are we?
Biceps here, so this stuff.
Not sure.
That's synovial it's extending down along the synovial sheath going along the biceps.
Mm.
It's really technically interarticular, but it's extending out past the joints.
All right, so we have a 40-year-old female with anterior shoulder pain after working out. Uh, Biceps looks okay. There is a lot of debris kind of is that within the sheath? Uh, Concern for like synovitis or. Yeah.
Mm-hmm. See, it also is extending down here.
Mhm.
It's a little shadowing on the ultra noise. Another synovial chondromatosis.
58-year-old with 2 months history of pain. So we have two axial views. Um, the second one is PD fat sat, and the first one is at a T1.
T1.
And it looks like there is quite a bit of fluid within the biceps tendon or the sheath. Is the tendon flattened or? So it looks like there's fluid that extends inferiorly within the sheath.
There's some in the sheath, but there's also some within the tendon itself.
Okay. So
It's split.
it's
Doesn't that look split?
What, John?
It looks split in a ganglion cyst.
Yeah, it's an intertendinous ganglion cyst here. Yeah, which is basically a partial tear with communicates and the fluid is pressed into the tear. It's pretty uncommon. Kind of what you see often in the infraspinatus, but it goes into the muscle. This is tracking down along the tendon, but hasn't yet made it to the muscle. Jason?
So looks like there is fluid expanding the biceps tendon. And the
And the
intra-articular
main
looks
thing is the
like there's
paresis.
a pretty fairly extensive tearing. Yeah, it looks like another ganglion.
Yeah. So it's another one. Okay.
Okay, rule out pec tear. Sure. Yeah, we're looking. Okay,
Hey,
so
John, can you go back to that last one? Yeah, that could be pressing on a axillary nerve.
Well, I think the axillary nerve is in here, isn't it?
No, it goes all the way around.
Oh, it goes all the way around? Okay.
Yeah,
Hmm.
it's a little proximal, but we don't know really how far that cystic area goes down.
Right.
okay, rule out pec tear. Looking at the pec major, the tendon looks intact,
Okay.
but there's some
T1 weighted image, so we can't really evaluate the muscle well, right?
right.
Let's go to a T2 weighted image.
Right, so there's a lot of edema within the muscle fibers So it looks like a partial tear. Pretty extensive tear, actually.
That's pretty.
And that's a
Yeah.
So this would be a grade 2 tear,
Mm.
probably not grade 3, because it has collection of fluid within it. So it's but is it surgical or non-surgical?
Non-surgical.
well. There's some people would ask you to put a prosthesis in there.
Okay, I'm not familiar with that.
Well, I had a individual from the Hollywood area
Oh, right.
to examine, and he had bilateral implants.
Yeah, the implants, right, but not to fix a tear, right? For
Oh, no, I know, but
purposes, for cosmetic.
some people might want to.
You mean you don't have your pec implants, John?
Me?
Do atrophy over the years?
No, the doctor decided not to do it.
Okay.
But I asked real hard. I offered a lot of money.
So the question here is,
And,
accurate?
uh,
Okay. How accurate are MRI findings in pectoralis major injuries? Anybody want to guess?
I would say very accurate, maybe like 98%.
Okay, if you have lack of tendon at the insertion, so you don't see it next to the bone, it's getting pretty close to 100. If you see edema contacting the humerus, the sensitivity drops a little bit, specificity drops. If you have just edema in the humerus itself, it's somewhat helpful, but not very good. Retracted tendon stump, they said, is not reliable. And the epicenter of the edema doesn't seem to be very reliable. But I don't, yeah. So, so basically, if you can't see the tendon insertion anterior to the biceps and the proximal humerus, that's a reliable sign that you're dealing with a tear, and if that's the case, they're almost all reparable. Okay.
So we have an axial and sagittal view. Looks,
So obviously a weightlifter.
yeah, muscles are very prominent. Um, Looks like there's some edema. Is
Okay.
curve.
So this is anterior, lateral, posterior, humeral head, biceps tendon. So where should the pec tendon be?
The pec tendon should be right around the area
It should be anterior to
of
it
the
here,
biceps tendon.
but
That's
there's no tendon there.
no tendon. Is that retracted? Is that the retracted bicep or pec?
So it's
Major
torn and retracted back to here, and here's that biceps tendon with hematoma around it. So this is torn off the bone, so this would be a surgical case.
All right, 16-year-old American football player, chest pain.
John, did you have a question?
Yeah, that's a long head of the biceps. That's the dark structure.
This is the biceps.
Yeah, okay. So this is, I don't know whether you could pull that to the humerus or not. Probably. Geez, I don't think I'd operate on that. But some people might.
Yeah, well, generally the sports medicine docs that I work with, they're really looking for these in their athletes to repair them. So
That they repair 'em?
yes, they do repair it back
Yeah,
the
well,
tendon back down to the bone.
I only seen it repaired once. I never had a patient that had this problem. So
Okay,
these are not that common where you can repair them.
okay.
But that's repairable. But it's a difficult one, and then you got a pretty big scar. Uh, and I suppose you could do that arthroscopically, but you better know what you're doing.
Okay.
All right, 16-year-old American football player, chest wall pain after block. So I think the tendon and tendon's junction of the pec major is intact, so we have like a muscular
You think
tear,
the myotendinous junction is intact?
right? Like right, there's a little bit of muscle right before the tendon comes
Right
out, right?
here.
Yeah, I guess it's not.
Here's the pectoralis major muscle.
Oh, I'm looking at the other adjacent muscle.
This is the
You
deltoid.
cannot
This is
suture
the humerus.
muscles.
What's this?
Yeah, that's the tendon
Yeah,
of
so
the
the
pec
tendon is still
major.
attached to the bone, right?
Yeah, but is that another different muscle adjacent to
And
it?
then that's the tear and the retraction. So the tear here is at the junction between the muscle and the tendon. And you can't really suture it to muscle.
The sutures won't hold; they'll just cut right through the muscle.
Okay.
So, the question sometimes is if it's in the middle of the tendon, maybe, but tendon doesn't really heal very well. Again, the bone grows into tendon. Maybe a little stub at the musculotendinous junction, but most of it, this is mostly a tear of the junction between the muscle and the tendon. And in my experience, most of these are not treated surgically. Though if they do believe there's some tendon there, some people might try. But generally the ones that are fairly universal treated surgically are the tears off the bone, and anything that has to do with muscle is generally not operated on.
Okay.
And there's nothing that we have to suture with that can hold muscles from tearing out. So um,
Okay, good.
we don't have any glue.
Good. Glue it.
Okay, so we have coronal views of the pec majors. Um, yeah, on the T2 on the right, I see some fluid on the right pec major laterally.
So you see there, and then there is some fat in here, and maybe some areas that on the T1 weighted image are lower in signal. So there may be both fat and a little bit of fluid around there. So that's actually fat. That's actually fluid.
Okay. Mm, okay, so sagittal, and we're looking at the pec major anteriorly. There's, yeah, some fluid between. I mean, is that the different heads of the pec major?
Well,
Maybe.
that's fluid within the pec major.
Okay.
So we see there, and then we can see the fluid in the axial images.
Mm.
And then notice that there's asymmetry. This one is kind of bunched up. This is the normal opposite side, which is stretched out like it should be.
Mm.
So obviously you've lost tension here because of a tear. And that's the
I
fluid.
advise silicone.
Mm.
So the question is it surgical or non-surgical? A little bit of tendon here.
Hmm. Yeah, I would say
It's
non-surgical.
non-surgical, John.
Yeah. So this was an old tear. The patient had a history of prior tears, and then now has a new uh, tear, which was primarily was substantially involving the muscle itself. So this was deemed to be non-surgical.
Now, some people would want to put silicone in it.
Okay.
Nobody I know, but
Okay.
there are a lot of people in Hollywood that would.
Okay.
All right, so we have a 64-year-old female with anterior shoulder pain And on the PD fat sat imaging, it looks like there's a lot of edema kind of anterior to the glenoid and maybe even anterior to the coracoid.
Yeah. So there's a lot going on here that may involve the subscap, but let's forget that.
Okay. So maybe anterior to the coracoid there's a lot of edema as well.
Yeah. So what's that over there?
Let's see. Yeah,
So what's this?
that's the biceps.
It's a short
Short
head,
head,
right?
yeah.
Short head of the biceps. So what's the structure there? And that's a pectoralis minor structure.
Okay.
It also attaches to the coracoid process there. And just again, that anatomy, short head, long head, pectoralis minor coming up to the coracoid and the coracoacromial ligament coming across there.
Yeah, it would be pretty hard to tear the minor without straining the major.
Yeah. All right. Well, why don't we stop here? We'll start instability of the shoulder on Monday. Okay.
Thank you.
Have a good weekend, everybody.
Same with you, John. Thanks.
Thank you.